I would like to start my presentation. So during this talk, by the end of the conversation, you should be able to identify the components of the clinical assessment, reflect on a hands-on versus hands-off approach, and hopefully we'll have some movie clips to help you along. Look at clinical assessment from a historical and evidence-based perspective, and then look at how we can use best practice methods to enhance that lost art. Even though I really can't see some of you, I would like you to be engaged and interactive and encouraged, and raise your hands virtually, of course, so that we can all become engaged in the process. In terms of the components of the clinical assessment, the first topic is, what does that mean to you? At the basic level, it includes the standardized forms of inspection, palpation, percussion, and auscultation. It also can relate to the use of nursing process model, where assessment leads to diagnosis, planning, implementation, and evaluation. Included in the assessment process is the use of testing and diagnostics, as they contribute to providing additional information. So first we need to have a baseline, and then we need to trend results and measure outcomes. So we're going to look at everything. We're going to look at listen, look, and feel approach. So here's a quick question. Anybody know who this person is? Looks like a distinguished gentleman. If you look at the bottom, it says WWOD. What would Osler do? Believe it or not, this is a gentleman who is a master diagnostician who started the teaching at the bedside and revolutionized medical practice. One of his famous quotes was to make thorough inspection. Medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from the words heard in the lecture room or read back from the book. See and then reason and compare and control, but see first. So let's think about this. What would Osler do?
William Osler. Osler was a Canadian physician and one of the founding professors of Johns Hopkins Hospital. He emphasized bedside teaching, clinical observation, and the humane treatment of patients.
So let's look at history and get some perspective. On the left, sorry, always happens when you are lecturing here. On the left, we have individuals' names, famous people. On the right, we have the sort of the timeline looking at when things were established. So let's look at the history of the physical exam. How did we get here? It started a long time ago, and several academic scholars started the pathway towards what we now conceive as the physical exam. If you look at the items going historically here, A and P, we take that for granted that they were already together. But if you look at it, and the anatomy text was first published in 1543, the corresponding pathology was in 1761. So it's taken a long time to get where we are. If we look at the stethoscope, it was discovered in 1816. And now, unfortunately, it becomes a fashion statement. So Osler, what would Osler do? He established the concept of bedside medicine, incorporating the physical exam, use of senses and equipment, stethoscope, otoscope, ophthalmoscope, and a percussion hammer. So we're going to start at the beginning with physical assessment. We need two things. We need a patient, we need someone to examine, and we need a practitioner or provider. You need someone to actually do the examiner. So raise your hands again. As we all agree, we need to have both components. The irony is that with simulations, the patient has become the disconnected mannequin. Think of your first experiences when simulations began. I know at the college when we started them, we had a voice box which we used with the simulators and the mannequins to simulate a response, to provide feedback. And then as the mannequins became more advanced, they began to moan and have other sound effects. So think of your first experience with a physical exam evaluation while you were in school. Did you perform the skill on another person, a student or a peer? And then there were introductions, and there was an immediate focus on a particular skill or task. Even a comprehensive head-to-toe physical exam required a specific format. And then there was little room for clinical decision-making, so because it became almost like a checklist approach. So how can one become a clinical practitioner if they are not being challenged to think aloud about what they do? So let's play What Do You Think? Okay, we're going to do some real world examples. So here's our first example. Patient admitted to the ER with a hypertensive episode. The BP was documented. They've already taken clonidine. Patient barely able to keep their eyes open, resting quietly in the bed. And then the healthcare provider enters the room to make an assessment. So let's see what happens next. Look at our choices here. And I put on my own virtual hand waving here. The healthcare provider comes in the room, crosses their arms against the entry door with a mask and a glove. They give an order for Ativan, telling the patient that they must be anxious. Now remember, the patient is barely awake, just resting comfortably. The healthcare provider never touches the patient to perform an exam, and then the healthcare provider orders additional testing. All of this happened. Are you surprised? Let's do another example. Again, real world example. Patient admitted to the ER 2 weeks post ERCP procedure, has complaints of severe pain in the right hip. Temp is not elevated, but the pulse and the blood pressure are elevated. A CT result reveals areas of concern, a possible infection or an abscess. LFTs are elevated. And the healthcare provider calls in, this time via the phone, okay? So what happens next? Well, healthcare provider states they've seen this 100 times. Nothing's wrong. It's a pulled muscle. Send the patient home. Healthcare provider thinks the labs are not accurate. There's no cause for concern because the patient's not running a temp. This is an overread, the healthcare provider says, and the healthcare provider is diagnosing this all over the phone. Again, all of this happened. Are you surprised? Well, another example, you're walking onto a hospital unit this time where nurses are seated in the hallway with their corresponding cows, the workstation. Change of shift report has already taken place, and then the nurses start to enter the room. Well, let's see what happens next. A nurse comes in, introduces herself to the patient, doesn't perform any physical assessment. A nurse comes into the room and wants to remove a Band-Aid from a thoracentesis, focusing on the anterior chest and abdomen. A little bit strange. The nurse is told that the patient's short of breath, comes into the room and doesn't do anything, just looks at the patient. And my favorite, the nurse states, "I don't know, I just got here and finished report." All of these happened. Not to the same patient, but all of these happened. And our last example, looking at the real world, okay. You are in the office, you have a scheduled office appointment with your healthcare provider. Now remember, in the other examples, we were in the hospital acute care setting. This time the med tech comes in, takes vital signs, uses automated equipment, and then you go into the examination and treatment room, and here comes your provider. So what happens next? Well, the healthcare provider starts entering documentation. They don't physically examine you. They document on the portal, when you get to look at it, that an entire head-to-toe physical exam was performed, and yet you know it wasn't. Why does this happen? And, you know, we can say, well, it's justifying billing, but how can we stop this from happening? And again, all of this happened. Are you surprised? Which comes to the focus of why the lost art of physical assessment, hands-on, hands-off. Well, I sort of got the inspiration from the Karate Kid, wax on, wax off. Let's see if we can get some wisdom.
Wax on, wax off. Breathe in, breathe out.
So Let's look at this and say hands-on versus hands-off. Well, first of all, inspection is the first building block of physical exam, but it's only going to get you so far, as we will see. The second important part is you have to actually touch the patient. And this can be a real conundrum because a lot of times, especially in a post-COVID world, we don't touch, we look from afar. Communication as the third step involves both verbal and nonverbal cues, but again, it only gets you so far. And then interpretation, putting it all together, and then trending and adapting results to improve outcomes. So we have to put it all together and actually touch the patient. If we do a review of the literature and we look at the historical and the evidence-based practice, we have a couple of different categories here. So what does the literature tell us? Well, history provides us with a stepping stone. If we think about Osler and what would Osler do and bedside medicine, we already have it established, okay? But we've sort of lost that dynamic interface. Research, as we know, can be retrospective as well as prospective. And clinical practice definitely should remain at the bedside. We need to get back to that practice. And unfortunately, or fortunately, AI and beyond, what is going to become of us? And again, a movie reference, we're getting into Skynet and beyond, because now we're beginning to see policies relative to academic instruction as how to use AI or incorporate it. But let's look at the literature and see how we impacted or had barriers that led us to the lost art of physical exam. All right, so we're going to step through the literature now and look back at things. One of the things that we know, and we should know, is there's a gap between knowledge and translating this into practice. This is something we see in clinical practice and nursing school all the time. You can have somebody who's academically book smart, and then they can't work or identify or interpret in the clinical setting. So knowledge translation tells us it has to be an iterative process. You have to keep doing it. You have to, do it and perfect it. There are also some issues at the structural levels. So there's at the individual level, there's the meso or the organizational level where you have education, resources, and training. And then you have the macro level where you have policy and stakeholders. So every level, every person has to contribute to build on this physical exam translation. When we look at historically, also, we look at the physical exam and we look at it as subjective, objective, Gnostic, pathic. We have to incorporate both things in order to get that information. If we look at the physical exam in terms of the research, it is a cornerstone of medicine. And Stanford Medicine says it is a privileged human interaction within an age-old tradition of laying on hands. So it is very, very important that we incorporate this and not get away from this. And now, especially when we're looking at AI and incorporation, we have to look at the science and art of clinical practice and how that affects patient care. Moving forward and looking at impacted barriers and looking at research and practice, there's a lot of qualitative research out there. And basically, it signals to isolated tasks. So when you look at the physical exam, one of the things Kelly and her research, the physical exam signaled what is called being there, that patients felt that they were better taken care of when somebody was actually touching them or listening them or emphasizing laying on of hands. Additional research shows that there are themes and challenges related to education, clinical practice. And one of the interesting things is competency-based education, because now we are transitioning now to competency-based evaluation in terms of NCLEX, in terms of nursing curriculum. So we now recognize that we need to validate and confirm that we are competent. And then we do have assessment surveys where they've looked at clinical tasks, and basically, again, the tasks were looked at in isolation rather than clinical practice or clinical decision-making. This is an interesting slide in terms of case studies to illustrate concepts. Unfortunately, there are people out there, there are patients, there are practitioners, probably us, going to our doctors respectively, where we've gone in and they haven't touched us or examined us. And we've used tunnel vision, so to speak. So there's research studies where a 28-year-old male was examined without touch, and they used tunnel vision. And what happened is that he ended up having an acute embolic stroke due to endocarditis, but it was misdiagnosed as Bell's palsy because they had tunnel vision. Another example was a 58-year-old patient who had a clinical diagnosis. They didn't perform a physical exam. They only relied on diagnostic labs and testing. And the initial diagnosis was a cardiac etiology, carotid sinus syndrome, but the actual diagnosis was they found that he had a lymph node compression rather than a cardiac etiology. One of the other things that we look at is computer documentation. And I know it's sort of funny because here we are on the computer and we're interfacing in a positive way to try and get information across, but it also can be identified as a problem in terms of it being perceived or received as an act of compassion and limiting that interface. One of the things with computer time is that it dehumanizes healthcare because the practitioner provider goes in and they're only looking at the screen. They're never looking at the patient. One of the other interesting research studies where they did in daily evaluation, and they asked questions to nurses and patients, like, do you feel as if your nurse or nursing assistant tried to get to know you? Do you feel that they made eye contact? Did they, call you by name? Did they touch you? So again, a very interesting way of looking at things that with our technology sometimes has dehumanized us. And we use our technology instead of really interacting with the patient. Another example of the lost art, really interesting research study of Faustinella and Jacobs. They gave some clinical examples, and I just want to share with you. Just think about this. Turn on the lights, okay? There was an actual, real world example, language barrier, and the group of physicians went in and examined the patient, never turned on the light. When they came back in on tending rounds, someone turned on the light and they found out that the patient had cellulitis. But again, the group of physicians that went in there before never turned on the lights. The second was, I'm not having a heart attack. Now think about this, chest pain. What's your classic differential? Cardiac, non-cardiac, okay? So here's this patient coming in and, they were having chest pain. And the ER physician, the docs and everything were like, okay, work up cardiac, rule it out. Well, the EKG was normal. No, they kept saying, you're having a heart attack. We're going to do further. We're going to do further. It turns out that someone came in and did a physical exam and the patient had shingles. So they were having chest pain from shingles, not a heart attack. And then the last one is talk to the patient. This is a true example again. Language barrier. It was a postpartum patient who had difficulty going to the bathroom, couldn't get OB/GYN appointment, came to the ER. They didn't examine the patient. They said, wait a second, you just had a baby, you probably have a UTI, we're going to send you home. Someone luckily came in and examined the patient, and guess what? She had a uterine prolapse. She didn't have a UTI. So basically, we have the decline of the bedside skill. Why listen with a stethoscope when an echocardiogram can provide the same answer? So again, go back to the basics. If you look at the research study and barriers, Climaco and NAMSI identified that, the physical examination skills appear to be declining as resilience on laboratory and radiology testing has increased. Proficiency in physical exam skills may lead to fewer missed diagnoses. And these are the barriers that they listed: the hands-off, the rounds, the targeted physical assessment, the lack of confidence, the role models. Another example I can bring up to you is think about CPR. We all go through CPR training. Now, at one point, years ago, showing my age as a nurse here, but at one point we were actually doing online CPR renewals without the physical exam component. And luckily they brought that back and said, you know, you can do some testing online, but you actually have to demonstrate competency. So again, think about CPR. You have to demonstrate continued competency and mastery. And that should be the same with physical assessment. And lastly, looking at curriculum revision and competency-based curriculum. Really interesting, Yale University in 2002 did a survey of their graduates. And believe it or not, the graduates revealed that many of them had never been observed while they took a patient history and performed a physical exam. And a lot of them felt ill-equipped, specifically in the physical focused exam. Really, really interesting. And if you look at it, in 2009, after that survey they did in 2002, they reinforced the physical exam. And also in 2010, again, so many years ago, Stanford University bringing back the lost art of the physical exam. Now, COVID has impacted us all on physicality. I'm not disputing that, but we're beyond COVID. We really do have to touch patients. And the eye patient has replaced the actual patient. So we have research studies where, again, some patients had never been examined. So back to what would Osler do? Remember, medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from words heard in the lecture room or read from the book. See and then reason and compare and control. Osler told his students, but see first. So, if you watch only one PowerPoint this year, only one. I know it's 2006, you know, beyond the 5 years, but this is a really, really good one to watch. It is the Spotlight Case Physical Diagnosis, a Lost Art. And it goes through all these different things and algorithms and reimbursements, but it also tells you how the patients value the physical exam. And the thing that's really, really scary is the bottom bullet. In the United States, internists can become board certified without having their skills at the bedside tested by certifying examiners. So definitely something to watch. So let's look at some best practice methods. How can we improve? How can we make a difference? How can we find that lost physical exam? So the first thing, it is an iterative approach, okay? A lot of times in healthcare and medicine and nursing practice, we do a checklist, we look at it and we never look at it again, or we come so focused on the checklist that we check everything and we haven't really actually checked it off. So we have a paper trail, we have a digital history, but was it really done? The second point is we now are moving forward to competency-based evaluations. NCLEX has gone to clinical unfolding case scenarios with students. Competency-based evaluations are the rage now for curriculum and accreditation. So we have to demonstrate that learning has occurred, but also that it has been maintained. The third thing, which is really important, is to mind the gap. We need to build the bridge. There's always between knowledge and practice. Like I said, some people can be excellent diagnosticians and not have a personality. Some people can be excellent in the clinical setting, and yet in terms of book smart academics, they don't perform as well. There is a balance. And lastly, that practice makes perfect. It is really important and critical that you don't overlook the obvious, but you don't forget to err on the side of caution. Consider and rule out, but don't let tunnel vision be your guide. Okay. If you watch one movie, here we go, one movie this year, okay? The Doctor, okay? And if you haven't seen it, it really is a great movie to see. And basically what happens is that the doctor ends up becoming the patient and sees healthcare medicine through a new world. So let's see if we can get this to work.
It's been an hour already. I'm out of here, people.
Has it been an hour?
Yeah, yeah. Hi. Sorry, I kept you waiting. Good. Good. Good.
Okay, well. Can you strip naked and put on your hospital gown as quick as you can? Dr. McKee, this is a joke. I'm not laughing. Alan. Roger. Money. Go. Sarah. AJ. Michael. Anything in the pencil? Actors who have spent a lot of time learning the Latin names for the diseases your patients might have. Now it's time to learn something simpler about them. Patients have their own name. Sarah. Alan. Yeah. They feel frightened, embarrassed, and vulnerable, and they feel sick. Most of all, they want to get better. Because of that, they put their lives in our hands. I could try to explain what that means until I'm blue in the face. But you know something, it wouldn't mean a thing. And sure as hell never did to me. So for the next 72 hours, you'll each be allocated a particular disease. You'll sleep in hospital beds, eat hospital food. Be given all the appropriate tests. Tests you will one day prescribe. Unbelievable. You are no longer doctors, you are hospital patients. Good luck. See you on my round.
All right, so thank you. I'm going to stop sharing and let me know if there are any questions.